I am recording now, and I'm going to go ahead and share screen. I'll see my email for a second here. There we go. Go ahead and start our slideshow and turn on the captions here. Okay, cool. So we were talking about, just to sort of back it up for a second, what causes intellectual developmental disorder. And so one of the things that we can look at are some of the physical disorders that can affect you neurologically. And so cerebral palsy is actually a group of disorders. I think people tend to think it's like one thing, but they affect a person's ability to move and maintain balance and posture. This is the most common motor disability in childhood. It's caused by abnormal development of the brain and or damage to the brain, sometimes through the childbirth process, sometimes, post-childbirth. Cerebral just means having to do with the brain. And then palsy means a weakness or problems with using the muscles. So brain and muscle problems. And depending on which areas of the brain are actually affected, they can have different symptoms. So they could have stiff muscles, which is called spasticity. They can have uncontrollable movements, which is dyskinesia, or they can have poor balance and coordination, which is ataxia. And again, if the multiple brain regions are affected, they can have multiple of these. So the most common type of cerebral palsy is spastic, and that's 80% of people who have cerebral palsy. They have increased muscle tone, their muscles are stiff, it's hard for them to move, and you would describe it by which parts of the body are affected. So you can look at whether the stiffness is mainly in the legs, which would then cause difficulty with walking. It's whether it is maybe only on one side of the body. In that case, it's usually more arm than leg. Or you can have spastic quadriplegia, where it is affecting all four limbs, the trunk, and typically the face then as well. These folks often have trouble walking and have other problems like intellectual disabilities and sometimes seizures, and occasionally it also is related to problems with vision, hearing, or speech, again, depending on which parts of the brain are affected. You can also have dyskinetic, and this is problems walking, controlling the movements of their hands, arms, feet, and legs, which does lead to problems walking and sitting even. The movements can be uncontrollable, and they can be either slow or writhing, so look more like a Huntington's symptom, or rapid and jerky, where it might look even more like a tic disorder. The face and tongue can be affected, and then they have a hard time swallowing and talking, and their muscle tone can change even during a single day. So they might feel really stiff at the start of the day and then like get too loose, and your muscles are too loose, there are dangerous that you could like hyperflex your joints, and that can lead to all kinds of problems. Ataxic cerebral palsy, they have problems with balance and coordination, unsteady when they walk. They have a hard time with either quick movements or movements that require a lot of fine motor control, like writing. And then they have a hard time controlling their hands or arms when they reach for something. And then you could have mixed. And the most common type here is spastic dyskinetic, but certainly any of these mixes. So this brings us into a nice transition into just talking about motor disabilities in general. So you can have kind of the symptoms of cerebral palsy in terms of the motor disabilities, but in the context of, not cerebral palsy. So fine motor disability is a symptom of a disease rather than a disease in and of itself. So it's sort of like a fever, right, as a symptom of a disease. But like, we're not like the 1800s and they'll just be like, oh, they have a fever, right? It's like they have a fever, why? Right? We try to figure out, is it an infection? Is it COVID? Is it meningitis? Is it the flu? Is it strep? Right? We try to figure out why. And fine motor disability is the same way. fine movements of the hands, but also the feet. I don't know if any of you have ever seen the like homunculus map of the body where it kind of shows where all your receptors are, and like makes the body parts proportional. So the hands are giant, but then also your feet are really giant. Again, something we don't think about, but our feet need to like constantly be feeling everything. Like let's say you're walking on uneven ground. It might have to sort of detect different textures, different levels at lots of different parts of the foot. And so obviously you can imagine that that might cause problem with walking as well. So you have integrated complex coordination between numerous neuroanatomical structures, there we go, and damage to any of those structures can cause this disability. And obviously, if you have damage to multiple structures, that can happen. You can also just have kids who have a delay in their fine motor skills developing. They might not be able to use their hands and fingers to hold, manipulate, and use objects at the time when developmentally we expect them to be able to. Fine motor skills also require hand-eye coordination. So you have to be able to see and respond to the movement of the hands and the fingers. So if there's a disconnect there, it can lead to this. The ability to speak also use those fine motor skills because the lips, the tongue, the face muscles have to all coordinate in order to make all these various different sounds and shapes that we need, right? They can also have delays in fine motor skills, gross motor skills like crawling or walking, or both. One thing that I think is really important to say here is, and I remember when we had like the Mayo Clinic's Your Baby's First Year book that we would use for reference, as my daughter was, 0 to 12 months. Every chapter had like a disclaimer box somewhere that said children grow and develop on their own schedules or something along those lines, right? Like kids will do things at different times, it's fine. And so what we really look at is sort of like, is this an outlier? Like it's months or years behind? But typically, particularly if they get physical therapy, occupational therapy for these things, maybe speech therapy if they need it, these kids are typically able to be fine later in life. But in some cases, it might be associated with another issue like autism or developmental disability, which is why I believe a student asked me to cover these last year, because I believe some of the kids they were working with at CVA were struggling with some of these things. All right, and then dyspraxia are movements with, problems with movement coordination, judgment, processing, memory, and some other cognitive skills. This impacts your ability to plan and process motor tasks in particular. And so you can sort of have motor-related learning difficulties, perceptual motor dysfunction, and developmental coordination disorder. So there are lots of different labels we can get to similar things. Symptoms here would be poor balance, poor posture, fatigue, getting tired really quickly, clumsiness, differences in speech, problems in perception, and then poor hand-eye coordination. Alrighty. One of the things I wanted to make sure that I included, because this is a problem at any point in the lifespan, is major depressive disorder. It's also really important to talk about this in kids because the symptoms might manifest differently. So at least 20% of adolescents have at least one major depressive episode. As many as 25% of the population will experience depression at some point during their life. That's not just kids, but just everybody. So these are the symptoms of a depressive episode, a major depressive episode. So you have to have at least one of the first two, and then 4 more symptoms. Now, if someone comes to you with a major depressive disorder, really severe depressive disorder, they might have everything on this list. Now, really interestingly, the standard here is depressed mood, but for kids, this often manifests differently. Kids can't say, I'm depressed. right? They don't have that language, and sometimes they don't even understand their feelings. Like right now, if my daughter is upset, she wants a Band-Aid. It's actually really endearing. It's like, I can't put it on your sadness, but if you want it on your finger, sure, right? If that makes you feel better. So in kids, this may come off as irritability, something along those lines. Diminished interest or pleasure in activities they typically enjoy. This is something called anhedonia. Appetite can change in either direction. Sleep can change in either direction. Psychomotor agitation, moving or talking more than usual. We would see this maybe in kids that have it. Typically in adults, we see what's called psychomotor retardation. And this is like using this word in the same way retard would be used in a piece of music. It means everything's slower than usual. People will even talk about a phenomenon, a sensation called leaden paralysis, where they just feel like it's really hard to move their limbs, as if their limbs were like encased in concrete. Fatigue or loss of energy, feelings of worthlessness or guilt, trouble making decisions, difficulty concentrating, and then sometimes recurrent thoughts of death, suicidal ideation, or attempt to die by suicide. The other thing we need to be aware of is the other side of that scale, a manic episode, elevated, expansive, or irritable mood. Now, I have to take like one step back here because, a bipolar disorder where you would have both depression and mania at different times is not that common in adults, but certainly is something that exists. Now, when I was finishing grad school, so sort of like 2008 to 2010 or 12 time period, it was really popular to diagnose kids with bipolar disorder. And it was just really problematic. It was like it was the new ADHD from the 80s and 90s. It was like every kid had it. And I think that's backed off of that for now, which makes me happy. But you can imagine just like elevated mood, bouncing off the walls, a kid with ADHD, or just a kid in general, right, being misdiagnosed. So here you need to have grandiosity, feeling like nothing can touch you, you're the best in the world, decreased need for sleep, very talkative, racing thoughts. Again, some of those things are just excitable kids, right? We want to make sure we don't overpathologize. Distractibility, increase in goal-directed activity, and activities that have the potential for painful consequences. So in adults, this tends to be drinking and driving, engaging in sexual behavior without the use of protection, things along those lines. You could also have a hypomanic episode, which is basically the same thing as a manic episode, just shorter. And as soon as it is severe enough that you need to be hospitalized to protect yourself or others, it becomes a manic episode when you're diagnosing. So in terms of the types of mood disorders, and these are really important to talk about in general, because you can find these at any life point. So I've been mentioning kids, certainly adolescents, adults. Major depressive disorder or major depression is the most commonly diagnosed psychological disorder. And older adults, we actually really need to be careful to screen for depression in clients that we think might have something like dementia, because some of the symptoms can look the same. And sometimes just having dementia can also cause you to feel depressed. So we just need to make sure we're checking that out anyway. So major depression is where you have at least one of those depressive episodes. Oftentimes it's recurrent for people, but it's possible to be diagnosed on your first episode. And then persistent depressive disorder used to be called dysthymia, and it just means you're just feeling sort of bad all the time. So like 2 years, you're just feeling low. Bipolar 1 and bipolar 2, you're going to have depressive episodes, and then also manic episodes for bipolar 1, hypomanic episodes for bipolar 2. Basically, as soon as you've had a full manic episode once, you're diagnosed with bipolar 1. And then cyclothymic disorder is where you essentially have dysthymia, but you occasionally have hypomanic episodes. And so this is just a nice chart that kind of shows the episodes and how they end up becoming diagnoses. I already said all this. Didn't know I had slides for that. We'll skip forward. Okay. All right. Next, anxiety disorders I wanted to go over because, again, at any life stage, these are really common. Generalized anxiety disorder in particular is very common. And then some of these other things you would see quite a bit as well, depending on your patient population. So anyone who would like come to me when I was in grad school and say, oh, I've always been a worrier, I would screen them for GAD. I would make sure that I keep that under advisement and I would look. Because these are people who just worry all the time. They have anxiety under most circumstances. They're always worried about something. Some of you may be self-diagnosing with this now. I jokingly say that I think I have a high-functioning version of this that generally can do okay until I get really stressed, and then I basically would be diagnosable. I think a lot of high-achieving people end up with something like this, but it's not always diagnosable. So the symptoms include restlessness, fatigue, difficulty concentrating, muscle tension, difficulty falling asleep, staying asleep. They have to last at least 6 months to be diagnosed. It can't be like, oh, you have a job interview, so you worried once, right? It's really common in Western cultures. Usually first appears in childhood or adolescence. And only about 25% of the people who have it get diagnosed with it. I think most people who have it just think like, oh, I just worry. Like, that's not a thing I can get help for, but you can. All right, when we think of anxiety, we largely tend to think of specific phobias. And so these are marked, persistent, and disproportionate fear of objects or situations. So the ones we think of are animals, like arachnophobia, fear of spiders, or fear of snakes. We also see fear of heights, claustrophobia, fear of enclosed spaces, something like thunderstorms or loud noises. And then also one of the more common ones is blood injection injury, where people are afraid of like seeing blood, having their own blood taken. That one obviously can be dangerous because it can keep people from seeking medical care. Immediate anxiety is produced by exposure to that object. And so they will avoid anything like that. So again, you got a blood injection injury phobia, you might avoid the doctor. Potentially very problematic, right? You have a spider phobia, you might not go anywhere you think you might run into spiders. Maybe you don't allow yourself to even like go for walks outside, things along those lines. And then you're going to have significant distress or impairment in your life from it. And so, for example, I had an elementary school teacher who was afraid of snakes. And if she had I think it's called a phidiophobia, snake specific phobia. And I remember she was like flipping through a National Geographic one time for our class activity, and there was a picture of a snake, and she actually just chucked it across the room. And like, luckily no one was there. She didn't hurt any students, but it was that immediate for her. All right, so agoraphobia translates to fear of the marketplace. So it is a fear of being in public situations. So maybe something like public transport. You want to say hi? No, you're just going to leave? Okay, Cindy's here. Public transport, open spaces like parking lots, shops, theaters, cinemas, being in line or in crowds, or just being outside at home alone. People who have very severe agoraphobia sometimes end up just never leaving their house. And it can be related to the concern that they wouldn't be able to get out of there. If something were to happen, maybe they think I'm going to have a panic attack and everyone's going to look at me. It's also common in people who have things like Crohn's disease, IBS, epilepsy, where they think they might have some sort of episode that would be embarrassing. So they'll avoid these agoraphobic situations, and the world gets smaller and smaller. and the symptoms typically last 6 months or more, and you've got that significant distress or impairment. Social anxiety disorder is another common one. So this is marked, disproportionate, persistent fear or anxiety about social situations. Now, for some people, this is narrow, like giving a speech, right, or performing on stage is a really common one. And the nice thing is, if it is narrow, the way it can be treated is just with a fast-acting anti-anxiety medication. You would just take it before you gave your presentation, be able to give your presentation, be good to go. But there are people who it's more broad, where they just generally fear functioning poorly in front of other people. They think they'll embarrass themselves in just like everyday conversation. And in fact, people sort of exaggerate to themselves and think they're doing worse than they actually are. Although I think in general, that's true of a lot of psychopathology. So they are afraid of being negatively evaluated, judged by other people, or by like accidentally offending someone. It's every time they're in that social situation, they're anxious. They'll avoid those social situations and have significant distress or impairment. All right, so panic attacks. And one thing I should say is that it's not uncommon for people to experience like a panic attack, like one panic attack in their lives. It doesn't mean you have panic disorder. And so panic attacks are really abrupt surge in intense fear or discomfort, come up within minutes, usually subside within, 10-ish minutes after that. You have to have at least 4 of these. Some people with severe panic attacks will experience every single one of these every time they have a panic attack. So heart's racing and pounding, they'll sweat, they'll shake, they'll feel like they can't catch their breath, they'll feel a choking sensation, chest pain, nausea, dizziness, chills or heat sensation. Sometimes they'll have like tingling in their fingers, paresthesias, derealization, feeling like they're not connected to the world around them, depersonalization, feel like they're maybe kind of watching themselves from outside themselves, and then fear of loss of control or going crazy, and fear of dying. So as you can imagine, a lot of people who have particularly these top symptoms don't think they're having a panic attack, they think they're having a heart attack. And so a lot of these folks might end up in the ER for something like that, and it can take a while to get it diagnosed. All of these are just an overreaction of our body's fight or flight system to something that's not like a lion, right? Something that's not going to kill us. So for example, all of the heart and lung related symptoms have to do with trying to take in more oxygen to get to your blood. The nausea is because your body actually shuts off digestion. It's like, we don't need to do that right now, we can do that later. The dizziness, which one always, and the derealization, depersonalization, feeling like you're going crazy, is actually because it slows blood flow to the brain and puts it to other places. Your body basically says, we don't need to overthink this right now. We need to just go, fight, flight, freeze. What are we going to do? And so the paresthesias are because it tends to divert most of the blood to your legs, because those are typically in humans more powerful, allow us to run away, things like that. Panic disorder is where you have a lot of different panic attacks throughout your life. And so they have at least a month of just worrying they're going to have another one, and then changing their behavior related to that. So there are ways that you can accidentally induce a panic attack in yourself by just like exercising, and your body's like, whoa, we're breathing a little faster here, panic, right? Things along those lines. And so they'll start avoiding all those things. They might avoid having sex, exercising, doing anything like watching scary movies that might get those symptoms going and have their body think that they're in danger and a panic attack. All right, so very interestingly, OCD used to be classified with the anxiety disorders, but in the most recent version of the Diagnostic and Statistical Manual of Mental Disorders, they created a separate category called OCD and related disorders, or obsessive compulsive and related disorders. So kind of recognizing there are different components to this than just anxiety. So obsessions are thoughts, ideas, impulses, images that seem to just be uncontrollable. They're not like voices in your head. They're just like ideas you know are yours, but you can't ignore. And then compulsions are repetitive and rigid behaviors or mental acts that people will do to try to reduce that anxiety. So these symptoms will take up a lot of time in people's day, hours of people's days, performing their checking behaviors or washing their hands, things along those lines. And so they'll interfere with their daily functions. All right, the other thing that used to be in with the anxiety disorders, but now got its own category, are the stress disorders. So the one that most people know of here is PTSD, post-traumatic stress disorder. Acute stress disorder is essentially the first version of PTSD. So your symptoms begin within 4 weeks of the event and last for less than a month. So there are some people who develop acute stress disorder and within the month are able to sort of work through their symptoms and be good to go. A lot of the folks with acute stress disorder, it will continue beyond a month and then they're diagnosed with PTSD. And symptoms of PTSD can begin at any time following the event. So for example, when I was at the VA in 2009, 2010, we had Vietnam vets, so from the late 60s, early 70s, who were coming in and getting diagnosed with PTSD for the first time, because a lot of them had been self-medicating for that entire time with alcohol. So, and then when they decided to get sober, all those symptoms came out, the nightmares came out. So you can diagnose them at any point. It doesn't have to be within the first 6 months after the event. So these are the symptoms of PTSD. So the very first thing you need is exposure to what we call a criterion A event, a traumatic event. And I really like how they revised this definition for the DSM-5. So it used to be much more specific, and now I think it really encompasses all the things people can experience that can cause PTSD. So actual or threatened, doesn't have to actually happen, death, serious injury, or sexual violation. Another thing that's not on this chart, but they added clarification on for PTSD, is that if it is for your job, watching it through media, actual or threatened death, serious injury, or sexual violation can cause this. And that's really great because I actually had a client while I was at the VA who, like, we decided we're just going to diagnose him, even though technically it wasn't clear we could at that time, who his job was to sit in a tent in Iraq all day and watch everybody's like helmet cams and CCTV. So just watch all the horrible things that were happening, right? That caused PTSD, even though he wasn't there experiencing them. And so I think it's really important to recognize that that can happen. So you've got intrusive symptoms. The most common intrusive symptoms people know about is flashbacks, where people actually feel like they're back in the moment. That's like one of the hallmark symptoms of PTSD. But sometimes they're just memories that pop out of nowhere, or nightmares that you have, or being really distressed of anything reminds you of the event, and having like physical reactions to that. I had a client who had gotten out of the Army but still worked civil service for Fort Gordon, which was our local Army base. And anytime anyone mentions Iraq or Afghanistan, he had to leave the room. He was working at an Army base in 2009, 2010. So that was a lot. So it really interfered with his ability to do his job. Persistent avoidance of anything associated with the event. And that can include people who were once your big support, right? If you were with your buddy on deployment and he was injured, right? Or she was injured, you might avoid them. Let's say you were sexually assaulted. You might avoid having even consensual sex that you would have enjoyed previously, right? Changes to your mood and cognition, inability to remember important aspects of the events. There's some evidence that suggests that's actually our brain trying to protect us. Exaggerated negative beliefs about yourself, that somehow you deserved this, right? Or brought this on yourself, not true. And persistent negative emotions. There's changes in arousal and reactivity. Hypervigilance is just always being on your guard. And it can go from anything to like making sure you never sit where someone can sneak up behind you, to I had a guy who had knee problems, but would still patrol the edge of his several acre property every night as part of his hypervigilance. They'll also, like, if you do happen to sneak up on them, they'll jump a mile, extreme startle response, or just trouble falling asleep, staying asleep. And then it has to have significant distress or impairment and last at least a month. All right, so now we're going to move into talking about more of the disorders that typically plague older adults, although unfortunately, some of these can affect adults at younger ages than you think. And these are our neurocognitive disorders. So these are going to be things like the dementias. And so there are now major and minor neurocognitive disorders, and then you specify the cause. So in some ways, the diagnosis of this sort of mirrors intellectual delay, if that makes sense. So for major neurocognitive disorder, you've got to have substantial decline in at least one of these areas. So memory and learning, attention, visual perception, planning and decision making, which are executive functions, language ability, and social awareness. And then that's going to interfere with your ability to live independently. So that's sort of one of the real cut points for whether it's considered a major or a mild neurocognitive disorder. If you can no longer care for yourself on your own, if you need someone to help you with basic skills, right, this would fall under major neurocognitive disorder. Mild neurocognitive disorder, you can have modest decline in one of those areas. And then again, you can still live independently. Obviously, you can be diagnosed with mild and then move into major as your symptoms worsen. So some people criticize this and worried that like we would over pathologize with the mild disorder in there. So we do need to be really careful when we are diagnosing it, that we're not diagnosing someone with a mild cognitive disorder when in fact they just have normal memory decline. All right, so neurocognitive disorder due to Alzheimer's disease is what we now call Alzheimer's dementia in the psychology world. So they have to meet that criteria for the neurocognitive disorder. Memory impairment is that early and prominent feature here, and you have to kind of rule out the other ones. For Alzheimer's disease, the time between onset and death is typically 8 to 10 years. So this disease is just prolonged. It can be really difficult. It's a really slow fade. Some people can live up to 20 years, and it often begins very mild. And so you can look like you're just sort of having normal problems of aging, like difficulties remembering names, things along those lines. But in fact, it's the start of Alzheimer's. Alzheimer's is one of the neurocognitive disorders that can actually be diagnosed much earlier. So there is a special genetic strain of this called early onset Alzheimer's, where you can actually be diagnosed in your 30s, which is mind-boggling to me, because that's like younger than me at this point. All right, delirium is also something we need to be very aware of with older adults. You can certainly get this at any stage of life, but we need to really carefully screen for this in older adults. This is a clouding in consciousness. It's a disturbance in attention and orientation to the environment. So you have difficulty concentrating, focusing attention, and thinking sequentially. That can lead to misinterpretations of what people are saying. illusions where it's like it looks like the wall is breathing or things along those lines, and a full-on hallucination sometimes. It is very quick. It's an acute change. It comes on out of nowhere. If you can figure out what's causing it and treat it really quickly, oftentimes all the symptoms will go away. And so you've got a disturbance in attention, and then you need at least one other cognitive domain, like memory or something like that as well. So delirium can be caused by something as simple as like a urinary tract infection, a UTI. In fact, that's a common reason why older adults might experience delirium. If it's misdiagnosed, if people are like, oh, well, they're just developing a type of dementia. It can lead to really bad things because, you know, if you're not actually looking for something to diagnose and you miss something that can be treated with antibiotics, right? That can, in fact, have sort of a cascading effect and cause problems down the road. So this is something that we always need to take care that we're like actually screening. You can have neurocognitive disorders due to a whole bunch of other reasons. So probably the most common type after Alzheimer's is vascular. And this is after some sort of cerebrovascular incident, a stroke or mini strokes. So it can be one big stroke, or it can be people who have TIAs, which are mini strokes where they might not even know they had a stroke. They just sort of like zone out for a minute. And in a stroke, blood flow to a specific area of the brain is cut off. That leads to damage. That leads to the neurocognitive disorder. It's progressive, but the really interesting thing is, whereas Alzheimer's tends to like decline pretty slowly, here you would actually see like the person's doing fine, and then the person's doing fine, and then and the or every time they have some sort of cerebrovascular accident, a CVA. And cognitive functioning may continue to be normal in the areas where the stroke didn't affect it. Hicks disease is also called frontotemporal dementia. This is a rare disorder that affects the frontal and temporal lobes and will look a lot like Alzheimer's disease. Prion disease, also called Creutzfeldt-Jakob disease, where you would get a neurocognitive disorder due to this slow-acting virus. And this virus can also cause spasms in your body. Huntington's disease is an inherited progressive disease in which memory problems worsen over time. The sort of signature of Huntington's, and why it's sometimes called Huntington's chorea, is movement issues. They sort of have these almost like sinuous movements, and chorea translates to dance. It can look like a dance. But you also see personality changes and mood difficulties. Parkinson's disease is a slowly progressive neurological disorder with tremors, rigidity, and unsteadiness. This is what the actor Michael J. Fox has. Alrighty, so next we're going to talk about what is sometimes called SMI, severe mental illness, within the realm of psychology. And to do that, we need to start by talking about what is psychosis. So psychosis is a state of being profoundly out of touch with reality. And like I mentioned earlier, when we were talking about delays and difficulties with fine motor skills, psychosis is a symptom, it's not a disorder. So there are a whole bunch of reasons why you could experience psychosis. And so just saying someone is psychotic is not really a diagnosis. Symptoms include hallucinations, which are seeing, hearing, smelling, tasting, feeling something that's not there through your senses. Illusions are fixed false beliefs that everyone around you can see are not true, but you can't see them. So schizophrenia, again, psychosis is this broad term. It's like having a fever. Doesn't mean you know what they have. Schizophrenia is a type of psychosis with disturbed thought, language, and behavior. Now, schizophrenia itself is actually probably more than one thing that we sort of grouped under this umbrella. I remember maybe 10 years ago, an article coming out talking about schizophrenia maybe being 8 distinct genetic disorders. But we still sort of classify them together, and partially because that's how we've done it, but also partially because the same treatments tend to work. All right, so here are the symptoms. I'm just going to skip to the criteria because that actually is easier to think about. So for schizophrenia, for at least a month, you have to have 2 or more of the following symptoms. So those delusions, those fixed false beliefs I was just talking about, the hallucinations, which are those sensory things that are not happening, disorganized speech. So this might include just talking in word salad, talking with words that aren't words or saying the same words over and over. It can include things like echolalia, repeating what other people say, clang association, rhyming words in ways that don't make sense. They'll have abnormal motor activity sometimes, including catatonia. And this is where they might hold weird positions. And then negative symptoms, which I will slide back here real quick for. Negative symptoms are symptoms that look like depression. They represent pathological deficits, things that a normal person would have that people with schizophrenia don't have the capacity for. So like they won't have full affective expression. They'll just have flat affect. Everything will be like this all the time. They'll lose motivation. Even a simple task like making their bed will be overwhelming. Sometimes they just won't speak at all. And one just quick note with the positive symptoms, which are those delusions, hallucinations, and disordered symptoms. This doesn't mean it's good to have them. It just means these are things over and above what the typical person would experience. So they have to have at least one of the ABC to be diagnosed with schizophrenia. Otherwise, if you're just looking at these two, right, this could just be depression or something else going on. They function much more poorly in life spheres prior to having the symptoms. So, they're struggling socially at work, things along those lines. And then they have to have at least 6 months total of impairment to be diagnosed with schizophrenia. There's also something called schizoaffective disorder. Essentially, those mood episodes we talked about earlier today, you're experiencing one of those at the same time you're having what was sometimes called the psychotic break, where you have the primary active symptoms of schizophrenia, those delusions, those hallucinations. You have to have been able to experience them when not experiencing a mood episode as well, because if you only experience the psychotic symptoms when you're in a mood episode, there's actually like a specifier under depression and under bipolar disorder for that. So for example, I had a client who would only have psychotic symptoms when she was depressed. Otherwise, she'd hear voices telling her to like harm herself. Otherwise, she never heard voices. And again, the symptoms do tend to overlap when you have the schizoaffective diagnosis. Brief psychotic disorder is like, boom, right here, 1 day to 1 month, you've got those positive symptoms basically, and some abnormal behavior, and they will return to their level of functioning that existed prior to the symptoms. So this is something that, again, like a day to a month, could just be a couple days you have this experience and then you're fine. You could also, similar to acute stress disorder, be diagnosed with this and then your symptoms continue beyond a month and then you move towards schizophrenia, right? Oops, sorry, I'm going the wrong direction. Here we go. Schizophreniform disorder is then, let's say you cross that 1 month threshold, but you're not at that 6 months you need for schizophrenia, you're diagnosed with schizophreniform disorder. And as you can see, the symptoms are very similar as well. You can also have something called delusional disorder, where you just have delusions. You've never had all the symptoms of schizophrenia. You've never had hallucinations. Your functioning is only mildly impaired. Your behavior is only minimally odd or bizarre, but you're having these delusions. And delusions can be things like the CIA is chasing me, the TV is talking to me, things along those lines. These are some of those thought disorder issues: disorganized speech, disorganized thought. So poverty of speech, just not talking that much. Poverty of content of speech, where everything's sort of vague and abstract. Pressured speech, loud, difficult to interpret, fast, talking a lot. Distractible speech. This kind of goes into tangentiality, but like a less severe version of it. Tangentiality would be where you're just like totally not answering the question asked of you. Loose associations are like you have trouble sticking to one topic. And then you can get to the point of word salad, where you just like nonsense is coming out of your mouth. And sometimes you'll say words that are like don't make sense for a sentence, but it sounds like, if you just listen to the tone of their voice and the rise and fall, it sounds like they're saying sentences, but it's words that don't make sense. Sometimes they're just having problems with logic. I mentioned the clang associations. Neologisms, they'll just create new words. Word approximations, where they'll just be like, oh yeah, I'm going to use this word in this way, and everyone else is like, what are you talking about? Everything is circumstantial, or just really difficulty having goals and sticking to them. Sometimes they'll just repeat the same word over and over and over. I mentioned echolalia, where they'll repeat things. Sometimes they have what's called blocking or thought blocking, where they try to talk, but it's like nothing comes out. Sometimes their speech is really stilted. They'll use like these outdated or pompous language tics, and they haven't done that previously, right? They refer everything back to themselves, even if it's not actually relevant. They can have word pronunciations, or they can just substitute inappropriate words. All right, so that is psychotic disorders. A lot of times people will confuse schizophrenia with dissociative identity disorder, which is on this slide. So the dissociative identity disorder is what we used to call multiple personality disorder. So this is disruption of identity characterized by two or more distinct personality states or an experience of possession. So the main difference between schizophrenia and DID is in schizophrenia, you might hear people talking to you. And DID, you are different people. You sort of become different people, and those people might talk to themselves. They talk to each other, even though they're all you. Sometimes they'll have gaps when another personality states, I've heard them called alters, like alternate personalities as well, will come out, and the main personality doesn't remember. And this will be beyond ordinary forgiving. And there'll be distress or impairment, and it's not just like they're different when they're using drugs, right? All right, next we're going to touch on our somatic symptom disorders very briefly here. Factitious disorders are where people intentionally produce or make up feigned symptoms. They'll go to extreme lengths. They'll take medications that they know will give them symptoms. They'll undergo, or sometimes they'll take medication for disorders they know they don't have. They'll undergo painful treatments or surgeries to rectify these things they're causing on themselves. So you can have fictitious disorder imposed on yourself, where you're doing these things to yourself, causing physical or psychological symptoms, presenting yourself as ill, impaired, or injured. To me, the worst one is fictitious disorder imposed on another. So here you're doing that, but to someone else. So if you're familiar with psychology, you might remember these being called Munchausen's and Munchausen's by proxy, as fictitious superimposed on another. So oftentimes these are kids, but they can be anyone who's sort of like in a place where they can't care for themselves. So you can imagine an older adult, an adult with developmental delays, who's dependent on someone else experiencing this as well. So here the caregivers will give the person in that vulnerable situation, whether it's a kid or whomever, medicines, poisons, what have you, to make them sick. And the kids or whoever will end up impaired, injured, have to go through all these different treatments. And typically, once they sort of suspect this, the best way to diagnose it is to take the kid away from their parent. And oftentimes you'll find that fairly quickly they suddenly get really a lot better. And so we see this as people who have medical backgrounds. Either they were sick as a kid, or maybe they worked as like a nurse, a lab tech, a medical aide, a secretary, or an administrative assistant in a doctor's office. Sometimes they have grudges against the medical profession. Sometimes it's just related to an underlying personality issue. Conversion disorder is also called functional neurological symptom disorder. And this is where it used to be called conversion disorder because the idea is your psychological stress or distress is being converted into these physical symptoms. And so they'll have all these symptoms, but they're not actually related to anything physiological going on. So they'll appear suddenly. A lot of times they're neurological symptoms. They're not related to the known physiology of the body. One of the most common examples is glove anesthesia, where the person will feel numb in their whole hand, but nowhere else on their arm. And like, that's not how the nerves work in the hand, right? And they'll retain most normal functions, but they won't know that they can. Right. So sometimes conversion disorder comes to where they think they're paralyzed and they truly believe it, but they don't realize that they could get up. If anyone's seen Talladega Nights, this is what Will Ferrell has when he thinks he can't walk, he thinks he's paralyzed, and he like stabs himself with a fork to try to prove it otherwise, and he can feel it. So there's the diagnosis. We just talked through the symptoms. Somatic symptom disorder are long-lasting physical ailments with little or no physical organic basis. To have this disorder, you have to have a whole constellation of symptoms. So you've got to have some pain symptoms, gastrointestinal symptoms, sexual disorder symptoms, and or a neurological symptom. And this can last for years, and they'll go from doctor to doctor trying to get a diagnosis. Oftentimes they're very resistant to the idea that this could in fact be psychologically based. You can have one that's specifically with the predominant pain pattern. Pain is the key feature here. And oftentimes when this is the case, they have had an accident or an illness that was associated with pain, but the pain they're experiencing doesn't relate to like the amount of damage that still exists. So there's actually whole pain centers that include behavioral health psychologists that address some of these things. What we used to call hypochondriasis is now called illness anxiety disorder. And this is where you interpret any bodily symptoms as sign of serious illness. This is obviously horrible in the day of WebMD, right, where people can really overdiagnose. And it can look like somatization disorder, but when you get down to really talking to them about it, you'll see that anxiety is the core. All right, so the next thing we're going to talk about is impulse control and conduct disorders. So these are things that can like, there's a whole sort of chronology, there's the word I'm looking for, chronological set of these, and it starts with oppositional defiant disorder. So this is something you would see in kids. If they get ODD, it does not mean they'll end up a serial killer, right? But it is potentially one step in that direction in terms of, unless we sort of intervene, these kids can go on to develop the other disorders we'll talk about. So they're repeatedly argumentative and defiant, angry and irritable. In some cases, they're vindictive. They'll argue with adults. They'll be very angry and resentful. They ignore adult requests and rules. They'll purposely try to annoy people and blame others for their problems. Then you move on to the more severe version, which is conduct disorder. And here you see 7 to 15. So we're moving up in age. Conduct disorder is more of a concern. Again, not everyone with conduct disorder, but a decent chunk of people with conduct disorder will go on to develop antisocial personality disorder, which is what we diagnose people who we would call colloquially sociopaths or psychopaths with. So they have a repetitive and persistent pattern of behavior where they violate the rights of others and or appropriate social norms for their age. So they have to have at least 3 of these: bullying or threatening others, provoking physical fights, using dangerous weapons, cruelty to people and or animals, stealing while confronting a victim, sexual assault, fire setting, deliberately destroying others' property, breaking and entering basically, frequent lying, stealing of items, frequent staying out beyond curfews, running away from home, and truancy from school. And as you can see, it has to start a couple of these symptoms before the age of 13, because they're like, well, some of these are kind of just stuff a kid might do to rebel, right? And we don't want to like over pathologize them. And significant impairment, notice you don't have to have distress here. A lot of times people with this disorder and with antisocial personality disorder will not actually feel distressed by their own actions. It seems like there are genetic and biological issues, but other things, drug abuse, poverty, traumatic events, exposure to violence, troubled parent-child relationships, inadequate parenting, family conflict, family hostility. Another related disorder is intermittent explosive disorder, where they have impulsive, aggressive, angry outbursts. Can be towards people, but also property or animals. And they're out of proportion with what just happened. You're like, whoa, where did that come from? They're very impulsive. They can cause distress and problems at work or home. We don't diagnose this in kids under 6 just because tantrums are a thing. Pyromania related concepts. All these symptoms basically come down to they enjoy setting fires. It's not better explained by something else. They're not like trying to get insurance money. They just enjoy watching stuff burn. Kleptomania, feeling like they need to steal things that they don't actually need to like survive. Sometimes they hoard them or give them away. Sometimes they even return them. It's not about the objects they steal. It's about that feeling that they want to steal. And so you'll see that there are different patterns. All right, so personality disorders are inflexible, underlying inner experiences that reflect in outward behaviors. They lead to psychological pain for the individual and can for the people around them. Personality disorders are just seen as something underlying. They're harder to treat and harder to change. And the main one I want to talk about here, kind of finishing our timeline from ODD to conduct disorder, is antisocial PD. So this is a pervasive pattern of disregard for and violation of the rights of others, starting at least at age 15, often beforehand. Have to have at least 3 of these symptoms, 1 through 7. Not conforming to social norms, so they don't care about lawful behaviors, doing things that they could get arrested for. Deceitfulness, lying, impulsivity, not planning ahead, irritability and aggressiveness, can be physical, reckless disregard for the safety of self and others, irresponsibility, And lack of remorse, in my opinion, is really the signature symptom here. The fact that like they will harm other people, whether it's financially, physically, what have you, and just not care, be indifferent. You have to be at least 18 years of age to be diagnosed. Otherwise, you're diagnosed with conduct disorder until you turn 18. And you, again, need to make sure it's not like in the context of something else. All right, we made it all the way through this review. Woohoo! Let me stop sharing screen and stop our recording. So hopefully that